Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 29 of the OBGYN podcast. This is a journal club for April 2018, and I am lucky enough today to have Dr. Ballas back with me today to go through this paper. And, you might have missed us in the last few months. Dr. Ballas and I both had some major life changes. Mine, like I said in the last episode, I got a new academic job and new house and all that stuff, and Dr. Ballas did something similar, and I'll let him tell you what he's up to these days.
Good morning, Joe. Yep, I am now in California. So I've officially moved back to my old institution, UC San Diego, where I did my fellowship training from 2010 to 2013. And now we are moving on back. The whole family will be coming over here, my wife as well, and daughter. And yeah, big move. I'm out here solo by myself right now, and then they'll be moving in a couple months. But it's good to be back to my old stomping grounds.
All right. Well, we'll keep everyone updated about how our new jobs go over the course of the time. You probably hear us talking about it. But today, what we're here to talk about is this paper. It's in the show notes. It's from AUDIPOG, and it is the Neonatal Morbidity associated with vaginal delivery of noncephalic second twins. It is done by Thomas Schmitz et al. From a group out of France. Takes place mostly in France. Now, this paper, we'll go through it bit by bit. Starting in their introduction, what I really like is that they really wear their bias on their sleeve here. They very firmly believe in vaginal deliveries for all twins, and they are not shy about telling us that right in the beginning. And they also get a little knock-in on the U.S. and basically tell us that we're doing it wrong. And I don't know that they're wrong, but we'll go through it in the paper.
Yeah, I don't know what the French equivalent of calling us chickens are, but they pretty much get to that in the second paragraph.
Exactly. Now, they do go through some of the literature that's been out there in the past. There was a big randomized trial from Canada back in 2013, published in the England Journal of Medicine. And in that, they found no difference in outcomes between planned cesarean and planned vaginal groups. And even in a 2-year follow-up, they found no difference in mortality or neurodevelopmental status. Again, you'll note that was done in Canada and not in the U.S. We don't really have many of these in the U.S. And then they go on and reference their own paper. That was from 2017. And that looked at all women with twins, with baby A being cephalic. And they looked at planned cesarean versus planned vaginal, and they found that planned cesarean actually had worse outcomes than planned vaginal, and most of that was due to RDS, which we do know is a risk factor with cesarean delivery. And other than that, there's not a lot of good data out there, and they stress that many times in the paper. There is a lot of retrospective, small cases, numbers, and so they really wanted to put some more information out there. And so they did this planned secondary analysis of their original study. And they do want us to know that this was planned from the beginning, that they were going to do this. It wasn't that they went back later and said, what subpopulation can we pull out? They always wanted to do this. So I guess, the thing for us to talk about before we even get into the paper is kind of the elephant in the room, is that in the U.S. we don't have a very high rate of either vaginal breech deliveries for singletons or for planned vaginal for twins unless both fetuses are cephalic. And then even then I've seen private doctors plan a C-section for 2 cephalic twins. What has your experience been, Jerry?
No, I agree that we definitely have a subset of generalists that even with cephalic, given that they're usually counseled a 10 to 15% risk of baby B becoming noncephalic in the course of delivery. Even then, that's going to be a non-starter for a lot of the mainly private physicians. Do definitely have some academic generalists that also, since they do have a plethora of practitioners around them that are willing to do deliveries, will also opt out of trying twin vaginal deliveries, regardless of cephalic.
Yeah, I mean, I think, being in academic practice before and now again, I will say that you you really have to practice to the, and I don't mean this in a derogatory way, but the lowest common denominator. If you have 1 or 2 people in your practice that are not going to feel comfortable doing something, it is hard to do that because we're only there for 12 hours. and then we're going to sign somebody out who is cephalic breech or even cephalic, and they're going to say, well, I don't do vaginal breech deliveries, so I'm never going to do a C-section. Right? And that's not fair to the patients either, to set them up with an expectation and then take it away. So it does make it really tricky.
Right. And as I discussed before going on, in my prior practice, as a group of MFMs, we made the decision to be available for those kind of situations. So if a patient was laboring twins and, like you said, a change of shift were to come along and there was a practitioner that was not comfortable, then as a group of MFMs, we were willing to come in, even if we were on call or not, to come in and manage that labor with them or without them, whatever their choice was, all the way through till completion.
And how often do you think that happens?
I'd say on average, I think about every other month, I'd say. We had they would also come in runs like everything in OB does, but I'd say on average, I had done it probably about 3 or 4 times during my 4-year stint, and we had about 6 MFMs in our group. So yeah, I'd say it's about every other month that we would be asked to come in or be aware or kind of be ready to come in for that kind of delivery.
All right. So you might just come in when they're close to delivery, or you might come in and manage it the whole time based on the preference of the generalist?
Yeah, typically it was when they were complete. They were starting to roll back because we did our deliveries in the operating room just in case a need for section for the second twin. So usually that was the point at which we would get called in. First time they're called complete, we'd make our way in.
Okay. Yeah, we tried to do something like that at Stony Brook, but with the mix of new MFMs we have, and some of them have comfort and some don't, and it was a little challenging to get that kind of coverage, but something we have to talk about again. So anyway, we can dive into the study a little bit. There's actually not that much to really talk about. It was a national, done in France, observational, prospective, population-based cohort study. It was done from 2014 to 2015, and like I said, this was a sub-analysis of that. Just to go into it a little bit, I kind of like the way they did it, where the obstetricians who did the delivery, and as soon as the delivery was done and patient care was taken care of, went and did a detailed web-based questionnaire about the delivery and the management and what happened. And then research nurses would take that data entry and then go back and collect a lot of the maternal characteristics and medical history and stuff. So I thought, A, it was a really nice way to do it. And second, wow, like they got all those obstetricians across France to actually sit down and do a web-based questionnaire after they did a twin delivery. I mean, God bless them. I don't know how they managed to do that. Good bribes, I think. Or it could be, I actually don't know what the healthcare systems in France is like. I think it's nationalized healthcare. So maybe that makes it a little easier if everyone works for the state, as opposed to being private practice and all that stuff.
Yeah, no, I think there is a nationalized system there, and there's something to be said for that kind of healthcare system creating a sense of unity amongst the doctors throughout a larger area than you'd say in the United States, where there's definitely pockets or local standards of care, dictated by specific hospital systems and policies and expectations of patients in different regions. So it's definitely much more fractured, whereas a nationalized healthcare system, I think, sometimes evens out a lot of those idiosyncrasies, I'd say.
Yeah. And also France is a relatively small country, right? So, I mean, compared to, it's probably like the size of Texas, right? It's not a huge country. Like the U.S. is very spread out. Then their primary outcome is a composite score of neonatal morbidity. You and I have talked to death before in previous studies about about composite scores. But when you're trying to do these big studies on very rare outcomes, sometimes you're forced to do a composite outcome if you want to talk about it. It is just, we all have to remember that a composite outcome inherently is not as good as looking at a real primary outcome. Right.
But that entire paragraph, there's one run-on sentence of all of the things included in their composite outcome, and it's actually impressive. I feel like it's almost above and beyond what some of the other composite outcomes you see in some studies. So they really tried their best to find reasons to increase a composite score.
Fair enough. I mean, and they did include things I've never seen included before, like humerus and femur fracture, spinal cord injury.
Yeah,
which I'm not even really sure how you do that in a neonate, but
with a breech, if you put too much traction on the hips and that breech. Kid extends ahead.
Okay.
Yeah, that's I think probably what they were going for breech, in that situation.
Gotcha. Mm-hmm. You can tell I don't do a lot of vaginal breech deliveries. So Dr. Bowles and here we're on the opposite end of the vaginal breech here. The only vaginal breaches I've done are by accident, essentially, where I didn't have any other choice. I'm not proud of that. It's just the way I was trained. So unless you have anything else to say about the the methods, they did mention how they basically use logistic regression for all their stats, which is fine for this type of study. Go ahead.
One thing I did like about it, actually, so typically we're taught that the randomized control trial is gold standard, and that's how you really want to study most outcomes and et cetera. But I like this setup of the prospective population-based cohort study because I feel like it actually presents a more real-world model for looking at the outcomes they want. Randomized control trials, especially in situations like this where there's a lot of variables like physician preference and so forth, whereas it may sound in theory that randomized control trials is supposed to kind of even that out. If you look at the randomized control trial that they reference, the twin birth study, like the C-section rate in the unplanned or planned vaginal delivery group was almost like 50%, right? And so automatically that caught my eye that are people behaving the way they're supposed to, quote unquote, with a 50% C-section rate in a group that was supposed to be a planned delivery rate. So I think this actually goes more towards a natural evolution of a labor, a treatment, a management, especially how they go into the fact that in France, they have a guideline and culture geared towards vaginal delivery of after-coming breech twins.
Yeah, I absolutely agree. You have to make the study narrow enough that you can find a difference so you can report that. But you have to also be careful that by making it so narrow that you don't make it generalizable, right? So it's always a trade-off in a randomized controlled trial between making it narrow and broad, right? And in this kind of study, because it's it's a population-based study, it is by definition broad. And it's not artificial, like you were saying. This is just what people do.
Right. Yeah. So, and randomized controlled trials also are ideal when you are either adding or subtracting a very controllable variable. If you are trying to add or subtract something like how to deliver a patient, I think you actually set yourself up for a lot of strange outcomes because tying the hands of a physician to a randomized block can be overwhelming. And not just the physicians. Remember, nurses are involved with labor management. The patient themselves are invested in this. That is a very big variable to just switch on and off based on how you randomized in a block. So that actually, I think, was a good call on this part, not to try to repeat randomized control trials for trying to deliver.
Agreed. So looking at the results, they had 7,901 women in 176 different maternity units, which is really a staggering number. And these women were all women who gave birth after 32 weeks and consented to the study. 3,900 of them had vaginal delivery of the first twin. They eliminated 109 because they refused to participate or they were mistakenly not included. And then of the remaining, 1,500 had a cephalic second fetus, 999 had a breech baby B, and 520 had a transverse baby B. So you're talking about half cephalic and half noncephalic, which actually makes very nice cohorts.
Right.
Interestingly, only 4 women out of all those 3,000 women had a cesarean delivery for the second twin.
Fascinating.
Now, that's a lot different than 50%.
Mm-hmm.
Right. So that does, again, it talks to the culture and the training and the protocols that they have in place at 176 different units. Go ahead.
No, I was going to say, in addition to the nationalized healthcare, you got to remember the medical training across not just France, but Europe in general is a little more standardized as well. And so I think that plays a part into it too. Expectations going into med school, coming out of medical school, going into training, I think has a lasting impact on how people practice medicine.
Sure. And just, to break down those 176 units, they did break them down by how many of these twin deliveries they did per year. And it was pretty good smattering. About 36%, or about a third, had less than 50 a year. A little over a third had greater than 100. And then, the rest, about 25% or so, were between 50 and 99, which is a lot, actually.
Right.
I mean, even 50 is almost, that's like one a week.
Right.
Right? So that's a good number. And then some things that popped out at me in their results that I want to talk about. I mean, we can skip it. Let's skip ahead, I suppose, and say that there's no difference in outcomes. Right. That's their big result is there was no difference in composite outcomes. So now let me step back, and they talk about this first part a little bit in their discussion. So I'm going to jump the gun a little bit, but they talk about the intertwin delivery, and there's some good data out there that say that the longer that intertwin delivery is, the worse the outcomes for the second twin, and that makes sense to me. Their intertwin delivery was between 4 minutes and 7 minutes. Right. Now, I've been there, in training. I did a few, even cephalic, and I will tell you that it was a lot longer than 4 to 7 minutes for most of them.
Correct. And we also had a practitioner who trained us who does have a different method of dealing with the aftercoming twin, which is a much more hands-off approach, a much more allow the labor to evolve, and not as much of an interventionist as a lot of the other teaching out there, which is after delivery of A, assess position of B by ultrasound, and as soon as you can, go in and get a part of the baby you can identify, whether it be feet, breech, rupture membranes, guide the baby down into the canal, and then proceed with delivery. And so they said that is their teaching and guidance in their training is for this active management of the second twin, which is either you will, if you have a transverse baby, you vert the baby to breech, bring the breech parts down, rupture membranes, and get mom to start pushing once it's feasible. And that's why you have this decreased lapse of time. So different schools of thought, but I still, I agree. Our training was similar back in the day, and I'm a little conflicted by this because when I do it, I do a much more hands-off approach. Now, they tend to not still go that far or that long, so I'm not sure where some of those past studies would have these really, really prolonged intertwin delivery times. But that is definitely an interesting tidbit I was also going to bring up, so I'm glad you brought it up too.
Well, one thing that you brought it up, you have had the fortune of training and working in several different hospital systems now. And so you've gotten exposed to, different people and their ways of practice. And I've really been at Stony Brook for all of my residency and afterwards. So it's interesting to me, like you were saying earlier about the different ways of practicing throughout the United States, how much impact one person at one institution can have on generations of obstetricians that get trained there.
So at Baylor, I actually had a older generation senior partner who still would evaluate women for breech delivery of singleton. If she really wanted to avoid cesarean delivery, if she was a multip, he would he was our main person. He would assess them. He would do pelvimetry. He would go through their history, and he would select candidates that were reasonable for a singleton breech labor, induce them, break their water, and he would actually come in and manage their labors. But it also does point out the fact that it's a dying art. When I first got to Baylor, I expressed interest in learning from him. And it quickly became apparent that, at this stage of my career, learning that kind of management, to have that kind of comfort, it was almost flip a coin if it was going to really happen, because they were few and far between. He had already had about 20, 30 years of experience on me. So that innate ability to assess and know whether labor is going well. And then the other part of it is the use of forceps on breech, whether you have pipe or forcep experience. That's the other elephant in the room is, breech deliveries sometimes do require instrumentation that we also have lost our training in this country.
That's absolutely correct.
So,
yeah, and that's, we'll get into it, I guess, when we get into the discussion here, but that is what all of this paper is trying to overcome, and I'm not sure that any amount of scientific evidence is going to overcome that cultural barrier in the U.S., but we'll get there, so hold that thought.
Right, and remembering, this was not done in the U.S., and we all know that that's a huge barrier for uptake of changing practice when a study is primarily not in the U.S., which is a whole other topic and a half.
I don't think anyone in this podcast is going to be surprised that people from the U.S. are geocentric.
Yeah, seriously.
The two other things that I found interesting, one, if you look at the birth weight, although it's not, the two groups are the same, 41% in one group and 42% in the other group were less than 10th percentile, which seems remarkable to me because, usually by definition, 10% of babies will be less than 10 percentile, which is why we have that. So to have that many, my only question is they don't give us the birth weight itself. They only give us the percentiles. So my question is, did they confuse something here? And were they comparing that against term? And that's why so many are less than 10 percentile, because they did have a lower gestational age. I couldn't really figure it out, but it seems really abnormal.
Yeah, less than 10th percentile, 40%. Yeah, I'd have to tease that out a little more. I'm not sure if that's something lost in translation.
It's got to be a mistake. Yeah, it's got to be a mistake, because, you can't tell me that 40% of the babies they delivered were IUGR.
Right.
That's something wrong in France then. We're not feeding French women enough or something. Or maybe they're smoking a lot. I'm not sure. So I think that there's something wrong there. I think that it was supposed to be something else. Because if that's true, well, then maybe that's why they had such good outcomes. It's because all these babies were tiny.
That's something to be said, because one of the criticism of the breech trial study that kind of ruined it for breech singletons in this country was the higher percentage of 4,000 gram babies in the breech group, which you can see causing possible confounding. So it's a very good point.
We have big babies here in the U.S.
Very good point. I was about to say, we tend to be on the larger side, and Europeans in general tend to be on the slender side.
Right. So that goes into it. And then the last thing is just going into their composite. The only thing I found that was interesting, and again, they don't give a significance on the individual things because they were so rare, but the endotracheal tube for greater than 24 hours, 1.4% in the noncephalic group needed the intubation for greater than 24 hours, and only 0.8% in the cephalic. Now, again, these are very, very small numbers, but it is almost a double. Anyway, I just found that interesting that there was that doubling and increase for needing tube. Now, probably doesn't mean anything, and in larger numbers, maybe the difference would go away. But that's really the only thing out of that whole table that I caught my eye.
I know one possibility is that, you've seen breech kids, even during C-section, come out more stunned, needing a little extra time to transition for whatever reason. Could this be a matter of pediatricians seeing this, knowing the kid was delivered breech, and kind of overabundance of caution in a way? Sometimes you just see that. That's one of the criticisms of some of the betamethasone trials, that if people knew that the baby didn't have betamethasone, instantly the kid gets surfactant. And so, could this be one of those biases where they see a floppy, breech delivered kid and decide to be extra cautious and just let them transition mechanically for a little extra time. Just a thought. I'm not sure.
Yeah, sure. Yeah. And that's really, I mean, it's a pretty simple study. There's not really a whole lot to talk about. And so I guess we can move on to the discussion. We've kind of already started doing this, and the big thing to me is, let me say, first in their discussion, they do go through why they think their data may be different from the other data. And I talked about some of that already. We talked about that, their protocols and the training and things like that. But if we're going to try to take this study and internalize it in our own practice, we were going to run up against a lot of the things that we talked about. It was done in a different country with different training, different comfort levels, nationalized healthcare system with standardized guidelines. And so to take that and then apply it to ourselves, it's dicey.
Like a lot of things, the term that pops up these days with a lot of these kind of rare situations are centers of excellence. This belief that can we regionalize certain procedures and certain desires so to improve outcomes and allow women the choice. So one experience I had during my time at Baylor was at the hospital we worked at, we were known as a VBAC friendly hospital. And so what we started seeing was a concentration of women seeking VBACs from hospital systems that didn't offer them anymore. And so do we see a situation down the road where certain institutions are identified as centers of excellence for vaginal breech or vaginal deliveries of twins and start concentrating women in these practices where there's an understanding that the twin delivery is vaginal by default if the first kid is cephalic? But that's almost, if you think about it, it's kind of a roundabout way of nationalizing a procedure in a way. So rather than doing nationalized healthcare, we're starting to develop these centers of excellence, which is just a workaround for standardizing things and expecting similar outcomes amongst different institutions that are willing to take on, certain risks. I don't know. It's
Yeah, I mean, I'll tell you that we have a population at Stony Brook that if there was another hospital, say 50 miles away, and they could go have a vaginal breech delivery there, they would go.
Right.
So if there was like one area per region that would do vaginal breaches and had hired people who were experienced, like your former colleague, I bet women would self-select to go there because they want to try to have vaginal delivery, and we just really don't offer that here. And other than that, I mean, I don't know I have a whole lot more to add to this paper. I think it's good. I thought that it was well done. I think it addresses an important topic. I just don't really see it moving the needle too much.
I mean, honestly, it's a project. All of these papers that were referenced, including the breech singleton paper that kind of, I think, really set it in motion that a lot of practitioners were no longer going to deliver any one breech, whether it be twin, singleton, or anything. It would have been nice to have these done 20 years ago, or even 25 years ago now, when practice was starting to shift, when we were at the height of kind of the C-section extravaganza. And maybe at that point, there would have been enough time to get it back into training or refocus or get practitioners to focus on having residents experience that. But it's almost like, the horses are out of the barn at this point. You have an entire generational gap that doesn't know breech deliveries, don't know forceps on a regular basis. We're victims of our own success because we have made the cesarean delivery safe. We have. But there's a tipping point. If you hand out enough C-sections, you're going to reach that tipping point where you're now having more negative outcomes, So, yeah, no, this is a tough one. This just goes ahead and kind of, I think, preaches to the choir. Unfortunately, the choir is getting a lot smaller and older. Yeah,
smaller and smaller. Yeah, I mean, actually, the last thing I'll say again, and I apologize to any of the French listeners because I really don't know much about your healthcare system, but I'm going to guess that you don't have the same level of malpractice lawsuits that we have in the U.S. And so, we could have the same exact outcome with a cesarean delivery versus a vaginal delivery, but we'll get sued for the vaginal breech delivery. And that may not be the case there.
And going back to what dictates regional practices and regional healthcare is the litigious nature of where you practice. I mean, I'm telling you, coming out of New York, Eastern Long Island, the epicenter of the cesarean delivery, epidemic, where there is no tort reform and will never be on the state legislature's, docket, coming out to Texas, a little different, in terms of, managing full-term labor, the whole other women's health issue I won't even get into. But, when there is finally a baby ready to be delivered, there was definitely more power in the hands of trained physicians to make informed decisions with their patients and offer vaginal deliveries after cesarean, be able to offer the breech noncephalic singleton. There's something to be said for that. There were things that I just would have never thought were still happening in obstetrics. So yeah, I think it again goes back to this kind of there's many dying arts in obstetrics, unfortunately.
Yeah, I mean, I don't want to make this about malpractice, but I was looking at some numbers the other day as part of my new job, and even within New York, the rate of the cost of malpractice insurance, even upstate New York versus Long Island, it's double in Long Island. Mm-hmm. And don't even talk about the rest of the country. I mean, we're basically like 100 times greater malpractice than a lot of parts of the country here in Long Island. So I mean, you have to be a fool not to think that affects how you manage patients. So, all right. Well, anything else you want to add? Any final comments?
No, this was fantastic. I'm glad we got back up on the horse. It's been a while.
It has been. Well, Jerry, I'm glad that you could join me here for the first episode. We'll call it the second season of the podcast. Sure, why not?
There you go.
And we should have some more episodes coming up soon. But until then, I want to thank everyone for listening, and thank you, Dr. Ballas, for your time. And
Absolutely.
We'll see you soon.
All right, have a good one.